Hi, everyone. I am a medical oncologist at the University of California, San Francisco. And I'll be chatting today with all of you a little bit about workforce diversity and why it is so important to follow up to David's points earlier. I'm truly grateful and honored to be talking to all of you. So I'm really excited to engage in our discussion moving forward. I'll present again how leaky really is the pipeline. And I think you really took it home with the prior introduction in terms of how disparate are the numbers in terms of representation of minority physicians in this country. And why is that really important? So there is a lot of data, both from business industries, from finance world, and also from healthcare that shows that diverse teams really outperform teams in which are homogeneous, whether that's in gender, but also in race. And we know that in healthcare, in particularly, there are benefits related to patient outcomes, to patient satisfaction, to adherence with treatment, to the quality of care being superior when diverse teams and physicians, providers who share cultural similarities, background, language with patients are able to care for them. We know that there are tons of disparities in this country, particularly in health and in cancer care, from screening to across the spectrum. And some of them are driven by things like trust and related to historical atrocities that have occurred in this country towards communities of color, both Black communities and Latino communities. And that is a huge barrier for us to be able to really diversify and increase access to clinical trials, but not just to trials, but also to healthcare. And I want to highlight that, we historically hone in a lot into trust as being a big barrier, which it is, but it's not just the only one. And I want to make the case for including the diversity of our workforce as one of the barriers. In the US overall, the issue is not just of oncology. This is the latest data from the AMC, which looks at all physicians in the United States from all different specialties, showing you that the majority, more than half, are white, followed by 17% Asian, and Latinos represent only 5.8% of all physicians, and Black or African American physicians are only 5%. So these numbers are extremely small, and we get even into smaller numbers when we speak about Native Hawaiians or Indigenous people. For specifically oncology, part of the problem is that training to become an oncologist and treat patients with cancer is highly competitive, and it is very long. There's subspecialty training. You have to go through medical school and continue through multiple barriers to what we call that pipeline that basically work as funnels in narrowing the amount of people that turn out at the end completing this specialty. And between all the different specialties that exist in medicine and treating adults with cancer, oncology is the least diverse of all of them and the one who has less underrepresented minorities and people of color compared to all the other ones. So here in this graph, in this table is showing compared to gastroenterologists, infectious disease doctors, cardiologists, you name it, we are at the bottom. And that is something that has not changed over time, unfortunately, which is what the graph on the right is showing, in which we are this turquoise line on the bottom. Despite many efforts, really, we haven't made any leadway or change over the last 2 decades. So we did a project last year looking at specifically trainees or fellows, which is the last tier of training before becoming an oncologist, and trying to identify specifically is the issue that people are after training, not going into academic practices in big cancer centers, medical schools, and going into other types of jobs, or are we just not enough? And as you can see here, between Hispanics are only 6% of current trainees, and African Americans 3.8. So the experiences of all of these trainees, similar to mine, is that many of us were the only ones in our institution. And for example, I train in UCSF, where I'm currently at, in California, and Latinos are almost half of the population of California. And I am the only oncologist that is Latina in my institution. And sounds horrible, but it's not rare and it's not the exception. It's unfortunately more like the norm. This, as shown here, it's even worse when we get again into Native Hawaiians, Pacific Islanders, and Indigenous Americans. And one of the big barriers is that this represents really a gap when we look towards what is that pipeline and the percentages of trainees that advance through time. So here in this graph, we are comparing to the United States population, and in the latest census, Latinos are, for example, 18% of the US population and expected to grow, and African Americans are around 13%. So those numbers are very different to our practicing oncologists, in which is this purple bar are Latinos of 4% compared to 18 of the general US population, and African Americans are 3% compared to 13 of the general US population. If we look again on every single step of this training path towards becoming an oncologist, from being in medical school, going through residency, and completing training, and then practicing as a doctor, we can see, for example, that Asian groups tend to be overrepresented. So this orange graph line or bar becomes bigger, as well as white individuals, which are not included in this graph for the purpose of being able to show you how small the numbers are on the minority aspect. Between Indigenous and Pacific Islanders and Native Hawaiians, the numbers are even less. As you can see, this is supposed to be a hot pink color line. It's basically absent because representation is so small at this point. So I think I've made at least, or show you data that I think it's quite clear that there are huge problems with representation and with having a workforce that shows and what the diversity of the United States currently is and will continue to be. And there's different ways in which we can approach this, and I'm just going to show some small efforts that are ongoing in trying to increase diversity in the workforce. And I think one of the most important things is mentorship and sponsorship, which is something that everybody can do, particularly people who work in healthcare, who are invested, who are in pharmaceutical companies, but even in communities. If you know somebody who is from an underrepresented background, who's interested in science and healthcare, who you can make introductions for, to get to know a physician, to go visit them or see them in their clinic, spend time with them, see what potential they can have in their life and career, I think that's still impactful. From the perspective of universities, of academic centers, there's still tons of things to do in terms of making sure that universities which primarily train and educate underrepresented minorities are supported, there's investment on them, and their graduates are treated as well as those who come from other types of universities. And then investment in pipeline programs, which are programs specifically built to support trainees from underrepresented backgrounds, whether those are racial or ethnic based, but also based on disadvantage from a socioeconomic standpoint, homelessness, and others. And I'm here highlighting only a handful of them, particularly sponsored by ASCO, which is our oncology society, because we are talking about cancer and cancer care and how to improve our cancer workforce. And between them, ASCO has developed over the years many different initiatives, which you can see here, that are particularly tailored to addressing different steps along that pipeline. For example, the Oncology Summer Internship is a new specific program that they have built over the last year that we at UCSF are lucky to be part of and that I'm currently leading, which provides exposure to what cancer care is for medical students during their first year of training. So medical school usually is 4 years long and is trying to get the earlier possible students engaged and excited about learning about cancer, about the research opportunities, but also the diversity of patient care that they can provide through the different specialties involved in providing care for patients with cancer. There's also opportunities and research awards that are related to students and residents that are invested in doing research in cancer. A diversity mentoring program that I'm also a mentor of, which similarly connects students throughout the United States from underrepresented backgrounds and medical residents with a mentor who may be a physician, a fellow, who shares their background to give them more of this life mentorship and perspective. And recently there's been the development of a couple of awards that are really key to skyrocketing and really building research careers for oncologists, like the ASCO Young Investigator Award. And during the last 2 years, Dr. Narjus Duma and Gladys Rodriguez, for example, have specifically fundraised to create one for Latinas, because Latina women, between oncologists and between medicine in general, are dramatically underrepresented, similar to Black men in medicine. There are other different efforts too invested in, for example, there's the YIA for researchers from also underrepresented backgrounds who are studying breast cancer disparities, which are specific similarly to try to advance DEI efforts and diversity in our workforce. So as take-home points, I think I've shown you a lot of data about how underrepresented women and racial and ethnic minorities are in oncology. And this is truly a call for action, for, I think, change and accountability from institutions, from our educational system, and from us as society in ways in which to decrease barriers for people to achieve, their academic goals, achieve education, and any professional goals that they have. And for us to think of this really as a tool to increase cultural competency, decrease disparities, and improve patient outcomes, which is at the end of the day what we're most passionate about.